we conducted a CT scan and found a significant 3D bone defect. I think it's class 6 of Cawood. No?
Yep.
Yes, that's right. Okay, this is the scan. So we can see the nerve, we can see the bone loss. And with our experience using the hygiene membrane, we thought, why not attempt to restore the 3D defect using this technique? If we can stabilize to implant in the 3 or 4 millimeters of residual bone, it should work, no? That's exactly what we did. So this is the case. We open it, we can see the bone. We placed 10 millimeters implants with 3 millimeters of bone anchorage, hoping to reconstruct 7 or 8 millimeters vertically. To ensure good stability, we hope for a 5 millimeter wide implant. Maybe 4 or 4.5 millimeter would have been okay. Then we put 2 hygiene membrane on this and the bone graft using sticky bone. This is the suture. We wait for 3 months healing, and we can reopen, and we can appreciate the quantity and the quality of the reconstructed bone on this occlusal view. What you see on the third picture is the intermediate abutment. The implant neck is located 1 millimeter lower. In this stage, we remove the membrane, place the healing abutments, and optimize the soft tissue. We will then allow the tissue to mature. So this is the case before the surgery. This is the case just after the surgery, and this is the case 6 months after the surgery. This is the same for the other implant. So this is before and this is after. I think autogenous bone graft is the gold standard for sure, but I'm not able to do this. I am specialized in aesthetic dentistry, not in surgery. So with this kind of tool, I can achieve a case like this. What are the success criteria for this kind of surgery? For sure, you have to add a good primary stability. You have to close without any tension, and you have to remove the hygiene membrane at least at 3 or 4 months after the surgery. So there is a future prospect for this technique. I think hygiene is a good membrane, but there is a new version with absorbable hygiene membrane. With that, we don't need a second stage of surgery. There is also an option for association with growth factor, and maybe we can make a custom-made membrane by 3D printing. So for conclude, I think this technique is reliable, predictable. I think this technique is less expensive for the patient and for us. It can do simplification for GBR procedure, and there are fewer complications. There is a lot of promising future perspective. So make it simple. Thanks.
Thank you. Thank you, Jean-David.
Thank you, Jean-David. Thank you. Thank you.
Thank you a lot, Jean-David, for this very instructive presentation and for the efforts you made to speak in English. Thank you a lot. So now it's time for questions.
Yeah,
Room, please.
Just a word,
some lights.
You understand now why in French we call Jean-David the couteau suisse, because he said he does aesthetic perfectly, but surgery performance are are good too. So thank you, Jean-David. Your English,
It's
yeah, it
shit
was
English.
nice.
Yes?
It was nice.
You understand
Yes,
everything?
Yes, yes.
Yes, I think so.
Thank you.
So, please, can we have some lights in the room so we can see who's raising his hand for questions? Yes, please. Micro?
Yeah, please feel free to ask some question about this membrane
Micro, s'il
hygiene
vous plaît.
or everything else. Pardon, chérie.
Ça va, c'est pas grave.
Hi, thank you for the lecture. Megagen has a few different types of screws, hygiene screws. Which one you prefer? The screw that distance the membrane from the implant. Which height you prefer?
Yes. I think the standard intermediate abutment is the 1 millimeter because you want the implant to be at 1 millimeter below the bone. But you can use maybe a 2, but I think 3 millimeter is too high.
Too high as a risk of exposure? Or?
No, not for the exposure, because at the end of the day, the implant will be 3 millimeter below the bone. So it's, I think it's not the good solution.
And what type of graft you use?
What type of?
Graft,
bone graft.
I used to use xenograft, and you can use what kind of graft it's work. I think it's work with everything.
Perfect. Thank you. Any other question?
Please.
Yeah.
We have 2 questions. Here and there. Raise your hand again, please.
Please, I would like to ask you a question today. Have you never a problem with the flexibility of this hygiene membrane? And didn't you sometimes have to fix it on the apex? Because sometimes you have some tension and the apex of the hygiene can move and the patient moves. So maybe for my own, sometimes I did a suture on the periost, crossing and go back in palatal to stabilize it. Have you any other tricks and tips for this?
Good question. I think it's a good, it's a good solution, but I am specialized in aesthetic, not in suture, you know. So I think you don't have to deform the membrane to put the graft. I think you have to put the graft and then you take the membrane and you put on the side. You know, if you deform the membrane before, yes, it will be difficult to re-put it in the good position. And the membrane, it's quite flexible. So I think even if it's a little bit deformed, when you put the periostom on the top of the membrane, it will be okay. I never had a problem with that.
Yeah, if I can interfere, maybe loosening also the screw will let us put it apically. If we fix the screw with a torque, it will open apically. But if we loosen a little bit the screw on the top, maybe it will get back fixed in the apex. Okay, we will take one more question.
Yeah.
Yes, please.
Hello, thank you for the presentation. I would like to ask you how deep, according to the bone crest, do you place the implant and why, first? And second, do you fix the membrane apically and when? And my third question is, do you cover the hygiene only with PRF or you cover it also with a collagen membrane or something else?
I never use a collagen membrane. I always use IPRF membrane. So this is the third question. What is the first one? Sorry?
How deep, according to the bone crest, do you place the implant when you perform the guiding bone regeneration with hygiene and why?
I place the implant in the good position for the final prosthesis. You don't have to think about the bone. You have to think about the better position of the implant for the best prosthesis, and after you do the bone regeneration.
That's what we call prosthetically driven implantology.
And the second question was?
My second question was, do you fix the membrane apically with
no,
a pin?
never.
He doesn't know how to do it, so...
I don't have any pins or screw at the clinic. Only a rubber dam, you know, and bonding agent to bond my veneers.
Thank you. Thank you a lot for your question. So I think now we end this first session of the morning.
Yeah. Okay, now let's just have a moment to celebrate our moderator and our speaker and to give them some certificate of appreciation that Megagen prepare for them.
Thank you.
Dr. Sherin Farhat and Dr. Jean-David Beauchatel. I love so much to say it in English.
Thank you.
Thank you.
Thank you.
Okay, let's move on to Megamind competition for now, okay? So I please you to welcome the aim of this competition is to create an assembly of young lecturers and to have a small competition between them. So let's do it. And they can come if you want to join me. Okay? You can come? The video first? Okay. Blackout. Okay.
고등학교 다닐 때 좀 많이 아팠었어요. 학교를 빼먹는 경우도 꽤 많이 있었고 아파 보니까 아픈 사람들의 마음을 더 잘 알 수 있어가지고 의사가 되면 좋겠다. 외과 의사가 되고 싶은 것이 제 꿈이었는데 제 아버지께서 오셨더니만 미래에는 치과가 더 좋아 보인다. 치과로 가는 게 어떻겠냐 하셔가지고 개인적으로 저는 학생들을 가르치는 걸 되게 좋아했습니다. 하여튼 가진 것을 나누어주고 또 학생들이 더 성장하는 것을 이렇게 도와주고 그래가지고 인스티튜트도 만들고 그래서 뭐 아주 페리오와 임플란트의 기초부터 제 주변에 있는 원장님들과 함께 이제 계속 공부를 했죠. 많은 분들이 묻습니다. 왜 그렇게 지금도 그렇게 진료를 하고 그러냐, 이렇게 뭐 그 정도 성공했으면 됐지 않냐 하는데 제 개인적으로 물어보시면 저는 치과의사 박강문이 더 좋습니다. 메가젠은 치과의사를 하면서 또 임플란트를 교육을 하면서 느꼈던 부족함을 이렇게 좀 보충하기 위해서 아무도 안 해주니까 그럼 내가 해야지 해가지고 만든 것이 메가젠이기 때문에 제가 갖고 있는 이 조금은 앞선 생각들이 이제 고갈될 때가 또 있겠죠. 그러면 또 훌륭한 후배 경영자들이 또 잘 이끌어 나가주면 될 거고요. 저는 개인적으로는 70살이 되면 이제 메가젠을 은퇴하고 미르 치과에 돌아와서 풀타임 덴티스트로서 하여튼 끝까지 할 겁니다.
The upcoming global event, the Megamind, will be even bigger and more exciting in 2024.
Exactly. We send everything to this and she does
able to function very good. 제가 언제 성장을 했는가, 내가 언제 임상적으로 좀 더 발전을 하고 새로운 것을 느끼겠냐 하는 것은 제가 보면 강의 준비할 때였어요. 그러니까 제 케이스를 리뷰를 해보게 되고 어떤 케이스는 잘 되고 어떤 케이스는 좀 잘 안 되고 했던 것에 대한 반성을 하게 되는 거죠. 신청자들께서 상당히 많은 고민을 하셨을 겁니다. 쉽지 않았을 텐데 이것을 통해서 글로벌 임플란트 임상가들이 전 세계적으로 자기의 엑셀런시를 내보일 수 있는 끝까지 최고의 경지에 오르실 수 있기를 소망합니다.
to this exclusive event. I thank everybody for coming to welcome us. I'm going to start with a quote. No matter what anybody tells you, the words and ideas can change the world. In 2022, Dr. Park and I came together to venture into a journey that we call Megamind. We had one vision that was to search and cultivate for the leader of future of dentistry. And here we are in our season 3 of Megamind 2025. More than 500 clinicians around the world participated in this Megamind project this year. And through the multiple rounds of competition, rigorous competition, top 21 contestants have competed yesterday, and now we have a top 6 of the best out of the top 21, and we call them the Cinderellas. And I can tell you, all of you are in for an amazing, pleasant surprise today. But before I start the 6 presenters, I want to thank those people who made this possible, especially the 6 judges that had the hardest time to score the top 6 presenters, because that is the hardest. So Professor Gagalo, Dinu, Makari, Kwan, and Durgan, and Dr. Leonard Schwartz, I thank all of you who are there. Thank you very much. And I also must thank the unsung heroes, those in the headquarters in Daegu, Korea. And we've met every week for the last 2 years, every week, Wednesday evening for 1 hour Zoom meeting to make this possible. Every time we start a season, it's a 10-month project. And those who are here, Sujin, Jinsun, Kate, and Selena, you're in Daegu, Korea. Hope you're watching. I thank all of you as well. Thank you so much. No further ado, time is limited, and I know you're a timekeeper. We're going to try to do this as best that we can and on time. The first presenter is from Spain. He is renowned for his digital workflow. Began his career at the San Pablo CU University in Madrid, Spain. He has also obtained a postgraduate degree in implantology from the University of Central Lancashire in United Kingdom. He has a true passion for full arch therapy. The title is Zirconia Monolithic Reliable in Full Arch Treatment? Let's welcome none other than Dr. Felix Wuchensfinnig Price.
Good morning, ladies and gentlemen. It's an honor to be representing all my colleagues from yesterday, the 21 dentists that did the presentation yesterday to me. We're all finalists. And the 6 of us today, I'm sure we will be representing all of you. So what I would like to do today is to share my experience in full arch rehabilitation over zirconia monolithic. I come from the south of Spain, and the first thing is to check what is our challenge on full X. Do not forget that these patients, they haven't been to the dentist a lot. We need to recover aesthetics, functionality. So we have a lot of things to consider. So a good plan, a good planification, digital planification, it is really important. My challenge is that I work in Spain, but once a month I go to the UK just to deliver this type of treatment. For this reason, thanks to digital dentistry, we can approach this situation. But because we have to deliver long-term solutions, because we cannot forget that, the patients, they want teeth. They don't want implants. So we need to make sure that with the teeth that we are delivering, they are properly done. For this reason, what I want to do is share my full arches since 2017. These guys on the screen, they were all done fully digital, with the same dentist, which is myself, and with the same technician. So out of 148 arches, we just had 11 fractures, which to me is a remarkable answer. The truth as well is that we know why the fracture happens, which is really good. 5 of them were because of my fault, because I wasn't familiar with the digital protocol to start with, because I didn't tighten enough the multi-unit, and then I delivered the impression wrongly. I gave the wrong information to the lab. So when I received the final zirconia, the passivity of the arch wasn't right. So the zirconia, you can love it or you can hate it. But zirconia is not flexible. So as soon as there is a tension or a problem, it will break. So in the other hand, the other fractures, they happen because of my technician fault. Because in anterior area, they try to individualize. Sometimes in anterior area, they didn't leave enough room for the zirconia. So if we don't have enough zirconia, it can break. But we identify the problem, and we are working on it to reduce these fractures. And one of them was a very atrophic maxillar, very big block of zirconia, and it broke. We did the test, everything was right, but it just broke. So for this reason, sometimes for those cases, we put titanium, and then on top, we cement zirconia. For every single case in my clinic at Cruz Laguna in Spain, from many years ago, we've been doing this step for every single patient. Some patients are more difficult than others, it is true, but we treat all the same. So the step 1 is collecting all the data to take some photos, intraoral scanner, and a CBCT. Once we have that, we put all together, and with our technician, we will design the project for the patient. So once we have the project done, the surgical guide, the plan where the teeth are going to be, then we go to step number 2, which is the surgery, and then after that, we will mild machine a PMMA full arch for the patient as an immediate loading. On the step number 3, the patient will be 3 months with this PMMA temporary teeth, and during 3 months after that, the step number 3 will come to do the final smile. So this step, to me, is the most important, because in here, if we don't do this right, we will end up having a lot of problems for our patient. So when we go to the photo, I asked my case today, his name is Daniel, heavy smoker. He has to travel a lot. And the problem for him is that he's very scared. He heard about bone grafting and things like that. And he heard that you need so many appointments to fix his teeth. And I said to him, OK, your teeth are a mess. We need to do an all-on-6, upper and bottom, and we need to do it fast. So give me your better smile, Daniel. And Daniel, this is the smile that he gives me, because the bridge is moving, everything. He's so ashamed of his appearance. The good thing is that from real picture, we can go to an STL. So we have a lot of information already. We give this to the lab, and then we start to rectify our plan, improving the functionality and then the aesthetics. But then as well, when we're planning the implants, we cannot forget, as Gallucci described, the 3D position of the implant. Apicocoronal, the implant needs to be deep enough. Mesial distal, we need to leave room between implants, between implant and tooth. And mainly, as well, buccal, lingual. Some areas that we don't have enough room, we need to respect the tissues. Otherwise, we end up like this. And this position will be the result of a bad prosthesis. So this is not the patient's fault, it's our fault. At the same time, we cannot deliver non-parallel implants. So nowadays, with the multiple programs that we have to make implants parallel, how we can deliver this type of teeth. And then if it breaks, then it's the technician's fault. No, I'm sorry, it's our fault, okay? So for this reason, Artugate is a good tool to me, because I can combine everything. I take the photos for the patient. My designer designed the teeth, so I want to have these teeth into my implant design program, because like this, I can guide my implants through the teeth, not the other way around. Once I have that, I will get the STL, and then we'll go to Artugate. I can remove Daniel's teeth, and I can place his design. And once I have that, then I'm going to decide where I place my implants, okay? In this top area, he didn't want to have a sinus lift, and then I said, okay, we will do one extension on each side, and then we will finish Daniel. Like this will be quickly. But then we have the project already. And also after that, we will check our 3D position planning. With Artugate as well, we can choose the multi-unit abutment that we're going to use. And it's fantastic because before the surgery, we're going to have the implants and the multi-unit abutment. The same thing happened at the bottom. We can remove Daniel's teeth, place the project, and make sure that the implants are guided through the teeth, not the other way around. Also, making sure that we don't damage any nerve structure, and if we know that we leave the implant position in the right place, the treatment will last, because that's what we're looking for, a treatment that it will last. So step number 2, we go to the surgery. At this stage, we can decide if it's going to be a FP1 prosthesis or an FP2 as a misclassification. So we can call Daniel, and I said, Daniel, look, we lost a lot of gamma bone already, so we're going to end up into a type 2 prosthesis. So we know, we haven't touched him yet, but we know a lot of things, that how the treatment is going to go, what he can expect. So after we design the implants, with Artugate, we can export the project of the 6 implants with the scan bodies, and then design the guide. We left a molar as a support. It's a gum-supported guided, and also we'll do some anchor piece in the front to give stability. At the bottom, the canines were kind of solid, so we have 2 molars at the back and 2 canines at the bottom. Like this, we can make real the implant position that we designed before. Then, in every single case, thanks to any rich surgical kit, we can collect bone and then keep the alveolar situation. And every tooth that we remove, we clean, we place our implants, and then we fill everything up. So this is Daniel after the surgery. The surgery lasts 1 hour and a half, 2 hours, everything guided, and these are the scan bodies that we're going to do for his impression. The same thing happened at the bottom, minimum invasive treatment, and everything is nice and tidy to take the impression and order the final. So this is 24 hours later, a PMMA ultra polished material that he's going to wear for 3 months. In the top area, we left with no extension yet because I didn't want to have an extension with PMMA because otherwise it might break. So 80% of the treatment, it is completed. So the promise that we did to this patient, it is completed. So we came from initial treatment to planning and to final smile. But if we do all that and the structure is not passive for PMMA or for zirconia, it will be a failure. For this reason, I work with a lab called Medical Fit, and we have a very precise passive test. Step number 1, which is called Medical Fit 1, we will take the impression of the implants, and because it's an edentulous patient, we will have a deviation. So in order to rectify the deviation from the STL, we can take the patient and take a CBCT with the scan bodies, and we send the CBCT and the STL file, and they will superpose. And like this, they can rectify the error. Like this, the teeth will be passive. If for some reason we don't have a CBCT in the practice, or we don't want to do more radiation onto the patient, what they provide us is a special tray. It's called Medical Fit 2. Basically, what we do is a pickup of the implants. We put analogs, and with your same intraoral scanner, you can take an impression and send it to the lab instantly. You don't need to post this tray. So like this, again, we will have a passive test. Once the teeth is passive, we're going to go slightly deeper. Are we going to use T-base over this multi-unit prosthesis? No. Because in the past, we had a lot of problems. They used to de-cement from the teeth, especially from the PMMA. They have to give you a lot of width into the emergency profile, and we want to respect the tissues. So for this reason, this lab increase the height of the multi-unit, making a longer screw and avoiding the failure or the fracture in the connection, because the problem was that the base was too thin. So this is the reason why they increased that. So in the PMMA and in the zirconia, we don't use regular connection. We use this type of connection, a modified. If we analyze the finite elements without the modification, you will see that it has a stress. It will have tension, so this will break. In the other hand, when we modify it, then we release the tension up to 6 times. So none of the fractures that I had happened on the connection. It always happened in the middle because it was an error of the impression or an error of not leaving enough zirconia. So this is the aspect, how the tension release over the modified base. If we go slightly deeper into the multi-unit T-base, when you go from temporary T-base to a final, first of all, it's shorter. And secondly, it's wider. So 2 bad things, because you need the teeth to be cemented on top of that, and you need to have room for the gum. So in anterior area, it's really difficult to work with these T-bases. And you leave less room for the zirconia because you need room for the cement and the T-base. So to me, it's not an option if the other, the modified base, it works, okay? The only advantage is that the fitting, it is slightly better, so you will have less leaking of bacteria, okay? But that's the only thing. But because we use multi-units from 2 or 3 millimeters, everything happens above the implant area. When we see the prosthesis without the T-base, then we have better things, because we screw 6 implants at the same time, and it's one block, and you know that nothing is not right, okay? You don't depend on your lab technician to check if the T-base is correctly cemented, or you know that all the implants are joined together, and you have more room for the zirconia. So for example, if we work in a FP1 and the lateral implants that has to be placed in this area, in this case, it's really difficult. First of all, the platform is nearly like the central incisor. And in this area, it is very difficult to make a titanium bar and then cement zirconia, okay? The reason why we want to work with zirconia is because not every patient can afford to pay a good ceramist, and not every clinic has an artist in the clinic. So we are moving to digital era, and this is the way to work with. I know that zirconia has limitations, but we can get the most from it, okay? So in this case, to me, working with T-base is a problem. But this is not working just for me. From 2016, they've been studying this protocol, okay? So apart from my experience, which is working, this has been tested to make sure that the passivity of the teeth is correct. So we go back to Daniel. We unscrew everything, and we need to see this sort of situation, because what we want is to last, the treatment to last, because we have respect the 3D situation. We have done a nice ultra polish temporary, then the gum it is like this. If you go to the bottom, even better, because we have less amount of gum, and it's working fantastic with the situation. So we decided to make a second temporary in order to have an extension, because I want him to get used to it, and he asked me to how he will be with the final. So I decided, okay, we will make a new one, okay? But this is Daniel. The smile has changed. His attitude has changed. He's not scared anymore to come to us. And the main thing to us is that the bone level of the implant, it is good and solid, okay? And I know that if he takes good care of this situation, the treatment will last good. So he even come and take photos. We are all the time playing around, and he has become an ambassador from your clinic. This is the best marketing that we can have. That patient that knows that you have done the most that you have in your hands to help him. So 6 months later, he comes back, and then we see, he said to me that he stopped smoking. I said the picture doesn't say the same. But anyway, resin for me is not a final solution, especially for him. He's a young patient, he comes in and out, and I don't want to have problems, fractures or staining in this case. So we go to the final smile. This is the biggest start today. On the top, because we had an extension, we did a titanium bar, we have enough room, and then we cement the zirconia. And at the bottom, we work directly to the multi-units. Again, all the teeth that I did before, only 5 of the 148 arches had this titanium. The rest are like the bottom. Believe me, I'm not lying, okay? And I don't have the fracture on the connection, because yesterday a lot of people asked me, so I wanted to clarify, okay? So we have ultra polish, as Gallucci described, make sure that you do a clean prosthesis that adapt to the tissues and the implants are in the right place, so this has to last on time. So when we analyze the finite elements, this is why we did the extension with titanium, because on the area of the premolar, it has an area where it's possible to have a fracture. So because we don't want fractures, then we did it this way. On the other hand, at the bottom, we have a nice and clean zirconia ready to be loaded for the bottom. And if you analyze the structure, it is good and there is no tension areas. This is the loading for Daniel. Nice occlusion, nice bite, tissues are adapting. He doesn't have a high smile, so we're good to go with that. So Daniel now comes to the office and he doesn't want to see, he doesn't recognize himself. Only in 3 appointments, apart from the new temporary, we have changed his life. And all because we have done a good project. We have done an easy step-by-step, okay? And this is where I think things should go. Now with the digital dentistry, for the new dentists that are coming, I think this is the way to work because we can analyze everything from the very beginning. So again, he plays around, he comes with the nurses, and this is his favorite photo to finish, okay? But to us, our favorite photos are this one. After a year, unscrew everything and see that the tissues stay the same, that there is no possibility, if he continues like this, to have a short problem in time, okay? The same thing happened at the bottom. Everything is nice and solid, and the hard tissues are good as well, okay? So this is the most important picture to me, to make sure that we have done parallel implants and we have done the promise that I did to Daniel, I accomplished. They don't know that they were going to be here, but when you have, they're not my parents. Some of you ask if they were my parents, but biologically it's not possible. They are not my bosses neither. In life, you choose family sometimes, and to me, that's what they are. So thank you. And just one, David, one second. Please, just, I won't cry, I promise. So, no, I need the image. Yeah. Yeah. So I was lucky enough to start to work with them 10 years ago. And I think if you don't have somebody slightly older than you guiding you through a protocol, through a way of work, it's very difficult as a dentist to improve. So we always have to have a reference. And I think in this big community, you're always trying to do this, to have somebody who is just slightly more experienced than you, and there is nobody better than others, just more experienced than you. Also, today, this is my lover, can you say, or whoever, is Dr. Miguel Murua. I'm from the south of Spain, and he's from the north, and we, from this year, with Megagen Iberia, we train younger dentists to use R2Gate, to planify everything before, to not have mistakes. Why we have to have difficulties when we can avoid all that? Because if you have given the best, or then if there is any problem, you can justify your treatment, okay? And the philosophy is to say, just guide it. Guide your teeth. You need to be surrounded by your nurses, good nurses, technicians, good materials. But somebody has to be the director of all of this. You just have to guide everyone. And if you go on good music, make sure that you explain yourself to the rest that what you want to do with all the new technologies and everything. Okay? So ladies and gentlemen, I hope you like it, and thank you very much for everything.
My name is Evelina Ginevičiūtė, and I am oral surgeon from Vilnius, Lithuania. And actually, honestly, it's a very big pleasure and honestly to be here with you all. So let's enjoy this time together. And I made yesterday a big mistake because I didn't say thank you for my mentor, for my teacher, for my critic, for my everything, for my science father. So thank you. Thank you, Thomas Linkevičius, for being with me almost 10 years. And now we can start our presentation. So take a look at this. A successful tooth extraction with previous infection. And in the end, we have this. Bone resorption like this. Is this what we want? Is this our success? And I hope that most of you would say no, because when implantation and infection is two things that we didn't want to bring in one, yes? But look at this molar and look at this infection. If you want to look a little bit closer, this is a TBC scan of this. And look how big infection we have here, how large it is. It's already connected to inferior alveolus nerve. And it's usually then, if we have infection, then healing, and then we have bone loss. And it's normal for us, yes? It's unavoidable. But what if I would say that implant placement into infected site could even be better and make better your results? So infection for us, it's like red flag, yes? Something that makes us to stop, reconsider, or even delay our procedures. So when infection meets implantation, we are saying no, right? But today, I want to be like this black sheep and to say yes for infection. So let's meet my patient, first molar. So this is the same molar I showed you before. This molar, this infection. So I said yes for this infection and for immediate implantation. And actually, yes, you cannot agree with me that we need to make implantation here, right? But I think that all of you will agree that we need to extract this molar, yes? And we need to make it carefully and atraumatically. Next, super important step is cleaning and disinfection of the socket. Because when we have infection, cleaning becomes critical. And I have a question for you. Is this site still fresh from infection? Can be good place for implantation? So what science is saying about this? Now I will show you two main studies that demonstrate that infection is not contraindication for implantation. So in this, you can see that we have almost 98% of success when we are placing implant in infected site. In this, we can see that there is no significant difference at all. So with this information, we can go back to our case and what we have after extraction and what we have after disinfection and cleaning. We have just a big, big hole here, and we have zero bone apically. We can see only a nerve bottom, yes? So to illustrate how deep it is, I placed just a drill from the surgical kit, and we see that the depth is almost 20 millimeters. It's almost 2 centimeters of hole. So in this stage, we are dealing not only with infection. The question is how to make implantation here and how to get primary stability here. So for the help comes wide implant. And I know that part of doctors don't like this implant, yes? They are always saying, please stop using wide implant because you will have failure, you will have complication, and that's it. But I don't agree with this. Because if you know how to use this wide implant, then it's predictable and successful treatment. For example, in this study, you can see that after 7 years, we have only 0.19 millimeters of bone loss. So it's nothing. So as you can understand, I put here a white implant just in the middle of the socket. And what about primary stability here? So it was perfect. This was more than 50 newtons per centimeter. And I want to highlight one more time. White implant is safe to use, but you have to know how to use it. So you have to place it deeper, 5 or even 6 millimeters below free gingival margin. Then you will be safe. And yes, it's immediate case, yes. So if we want to preserve our soft tissues, we have to make a bone grafting, yes? And I think that you want to ask me, infected site, acute inflammation, is it not too risky to make bone grafting here? Is it safe? And I can answer you that if you want to have a good profile, and if we made a proper cleaning and proper disinfection, yes, it's safe and you have to make it. And in the end, we place just a healing abutment. And of course, I could make individual healing abutment or to put anatomy healing abutment, but I put just the standard wide healing abutment. Why? Because it fits. It fits perfectly. So you want to look how it looks after surgery? And it looks like this. And I agree with you, it looks risky. It looks dangerous. It looks crazy because implant is just hanging in the air, yes? But be patient and wait. So 4 months, and what we have this. So it's perfect healing. We managed to keep our soft tissues, our bone, and patient also has no complaint because he has no pain, no swelling, nothing. Just 4 months. And 0 infection, 0 absence of infection, 4 months. So I think that most of you would not do this surgery. Why? Because it's infection, because we don't have bone here, yes? But look what we have when we did it. So now we just need to make a final crown. And our crown is from zirconia, it's screw retained. And I want to repeat myself one more time. 4 months, easy implantation, fast implantation, and we have this. What about X-ray? So after 4 months, we still have implant here, yes? We still have it. Our bone graft is here also. But what is also very important, look at this place. Look, our bone is healing. Our infection is healing here. 4 months. What is happening after 4 years? So we can see that our bone is completely healed. Any infection, our implant is still here also. Any bone loss around our implant, 4 years. And maybe you can answer me. Could we enjoy results, so stable results like this, without making this surgery? Instead of making big, long-lasting, painful surgeries trying to reconstruct the bone. And I'm sure that someone of you is thinking that, yes, it's incredible. Yes, it's wonderful, but it's just one case. And maybe it's just a lucky outcome, yes? And yes, you are right, because one case doesn't prove much, yes? So this is why I want to save myself a little bit and to show another case. Another patient, another molar, same infection, even bigger infection here. So again, patient come to us with pain, with swelling, with everything, with big eyes looking at me and saying, please, doctor, do something. And we have 2 solutions here. Extract, disinfect, and become a best friend with this patient for 1 year trying to put the implant later, or to make immediate implantation here. So as you can see, we made it implantation here, and with wide implant again. Because without wide implant, I cannot do surgery like this. So the same principles, deep enough, and the primary stability was also perfect. So again, bone augmentation in this case, and I put here individual healing abutments. 2 weeks later, what we have? No infection. We managed to keep our contour. Everything is in the place. So this is 2 weeks. Do you want to look how it looks after 2 months? So it looks like this. 2 months, and we have perfect profile. What about implant? Is still there. So we wanted to test it, and we tested, and it was 72 ISQ. What does it mean? It means that our implant is fully integrated. So now we have to start our prosthetic part net, and delivery after 2 months, just 2 months. I'm showing you the results. Again, everything is in the place. We have crown, we have contour, we have soft tissues, we have bone. We don't have any infection here. So you don't want results like this. And actually, I called for this patient 1 week ago because I wanted to make x-rays, photos for you. And she said, no, doctor, I'm not coming. Everything is good. No, Yelena, you have to come. No, doctor, I'm not coming. You need money or what? No, Yelena, please come. And she came. And she came, and I can understand why she didn't want to come. Why? Because everything is good. We managed to keep everything after 5 years. Look at the gums. Look at the papillas here. Everything is stable. So what about x-rays? X-rays we see, again, the same. Our infection is healed. We don't have any bone loss here, and we have stable implant here, 5 years. So from this to this in 2 months. So in the end, I want to say, I think one thing that please try to make your complications into your success. And then you will be happy, and then you will be enjoying what you are doing. So if you will be enjoying what you are doing, you will be happy, your husband will be happy, your wife will be happy, your assistant will be happy, your patient will be happy. So enjoy. Don't be afraid to take a risk because you don't have a boundaries. So thank you.
Hello, everyone. It's a pleasure for me to be among the speakers here today. My name is Nabil Ghusn from Lebanon, and today we're going to be crafting the optimal workflow in digital implantology. To introduce myself, I'm co-founder at periodontist at a private practice in Byblos, Lebanon, and I'm also instructor and researcher at the St. Joseph University of Beirut. I come from Batroun. It's a coastal town known for its beautiful sea, outdoor sports, and stunning nearby mountains. But as I stand here with you today, my heart remains with my country, with the current situation. And I hope that all the world will have a brighter, safer, and more predictable future. These principles also apply to my work, because predictability in implant placement and the safety for my patients are the two aspects I value most in guided surgery. But beyond that, as a digital enthusiast, I truly enjoy the process of digital planning. And it is in every case where I try to learn something new, to explore new digital techniques, and to improve my workflow from one case to the next. That's why today we're going to dive into the world of digital planning, and I'm going to present a case where it highlights some of the implementations I've implemented, some of the optimizations I've implemented in digital implantology over time. It's about a 72-year-old female who had no major health issues, but she needed a total rehabilitation for her teeth for functional and aesthetic reasons. But she was afraid to start the treatment. At the clinical exam, we see that the patient has a reverse smile, a disruption of the occlusal plane, teeth aggressions, deep bite, overjet, and many other problems. As a first step, we extracted the teeth that was causing pain for the patient and infection. And then the patient disappeared for a few months, but later she came back and she told me, I've struggled with my teeth for so long, and I'm finally ready to get a new smile that makes me feel good again. Will it be possible to make that happen? So in order to answer my patient, I had to do first the virtual prosthetic design. We did this by taking jaw scans and smile face scans with the Medit i700 and a full face scan with the Bellis 3D face scanner. We aligned all these models based on anterior teeth geometry and also based on nasal geometry. And like this, we had the intraoral models aligned to the face model. But now, if we take a closer look, and especially at the quality of the mesh in this smile area, we see that it lacks some depth and definition. And studies have shown that even with high-end extraoral face scanners, they struggle from capturing accurately this area. And it's not recommended to do anterior digital smile design with these types of face scan. But here, when I compare this mesh to the one that I took with the smile face scan with the Medit i700, I see that the latter has much more details in it. And because in my previous step, both models were already aligned, so I thought, why not combine both and adapt the full face scan to the smile face scan in this area. And like this, instead of having this type of non-optimized face scan, not showing the good relationship between the teeth and the lips, now we will have an optimized face scan that will be more suitable for our digital design. Like this, I can create some guides also to do our ideal prosthetic wax-up, and this is a great communication tool to share the patient what we would like to achieve with the treatment. And now that we know our roadmap for the treatment, we have to proceed to create the optimal virtual patient by adding hard tissue data to it. We will do this by taking a CBCT and by aligning it to the intraoral models of the patient. But here we can see in this model that we have a non-reliable zone for alignment in the posterior region, and we have a small but reliable zone in the anterior region. And this is one of the case scenarios where we have to do an alignment device in order to accurately superimpose the intraoral models to the CBCT. And one of the devices used is the EvoBite or the R2 tray by Megagen. That's why I've introduced previously what I call the DAD, or the Digital Alignment Device. So it's a device that is fully digitally designed. By that, it's aligned by default to the intraoral scan. So its advantages that we don't need to take or print a physical model, or to mount it with silicone material on the jaw, or to take a desktop scan in order to register its relationship with the jaw model. So we simply have to print this device, add the radio opaque markers in their design positions, and then insert it in the mouse and take the CBCT with it. And now we will have to simply align both models based on those markers in order to have an accurate superimposition between the intraoral scan and our CBCT. Now, what we did, this CBCT was uploaded to a validated AI segmentation platform, which is the ReLU. And with a series of software manipulations, Boolean operations, we merged the intraoral scan data with the CBCT data in order to create our optimal virtual patient model. This model features every single anatomical structure as its own entity. So here we have the bone with the extraction sockets, the teeth, which are created by a combination of the CBCT AI segmentation and the intraoral scan, and the gum as a solid model with the teeth indentations in it. Like this, we can seamlessly manipulate each model apart, do some virtual extractions, show our wax up, do some gum manipulation, and many other advantages we will see in the design phase. So now we have our complete virtual patient model. And we can proceed with our implant planning into the R2Gate software. So all this model was imported to our planning software, and the implants, along with their abutments, were simulated and placed virtually here. Now, an important step in the digital design and implant planning is the assessment of bone quality prior to the surgery. And studies have shown that with some CBCT calibration techniques, we can accurately achieve that. And some of the tools we use is the digital eye tool inside the R2Gate software. However, the report differs if we have an implant placed in a healed socket or an implant placed in an immediate extraction case. Because in this case, the gray density values of the tooth will be included in our report. And on one hand, it will mask the available bone quantity in contact with the implant, and it will also misrepresent the measurements of bone quality assessment. So, as a first step, in order to assess the bone quantity after immediate extraction cases, we published a technique last year where we made this assessment by measuring the potential bone-to-implant contact in square millimeter area. Like this, we could choose our optimal implant position, not just based on implant dimensions, geometry, and depth of threads, but also by checking the remaining available bone volume after the extraction. But now, it will remain to assess the bone quality in these sites. And I wanted to use the same digital eye tool in immediate extraction cases as in regular cases. So what we did, we have our segmented teeth from our optimal model. So we imported it to the 3D slicer software, and we applied a mask on the raw CBCT images to change the values of the gray density values of the teeth with that of airways, representing an extraction on the raw CBCT images. And like this, I won't have this report anymore, but I will have a more comprehensive report that will show me on every site the potential implant bone-to-implant contact with each type of bone, along with the total potential bone-to-implant contact. And now, on the other hand, I have also the bone density inside my drilling side, so now I can better adjust my drilling protocol according to this report. And I'm going to show you several sites in the same case to show you how we adjusted our drilling protocol based on the report that we had for the bone quantity and quality assessment. So now we're done with our planning phase. We can proceed to our guide design. And in this design, we also used this optimal patient model in order to choose and to create our guide support model for every step by doing selective extractions and choosing the right model for it. And also, we could do gum manipulation and simulate flap reflection in order to design our temporary restoration. Like this, the temporary restoration was designed based on the gum and the bone anatomy. And here, we can see that we made an oval-shaped pontics in order to preserve our gum architecture after temporization. And the last step is to print our guides, and now we will go to do the surgical intervention. Now, because our patient was sensitive and could not handle long procedure, we divided the surgery into two steps. In the first one, we placed the posterior implants in a guided way for the upper and the lower jaw. And in the second surgery, we extracted the anterior remaining teeth, we placed our remaining implants, and did our temporization. So this is the surgery for the lower jaw. We can see the pin guide and then the extraction of the anterior teeth, the placement of the surgical guide, drilling and placing for the implants. Those are the implants placed, and we made a small flap retraction in order to do our bone leveling required for the prosthetic temporization. So this is the immediate temporary. It's a hybrid 3D printed temporary. And this is the surgery for the upper jaw. It's the same way. This is the pin guide. We left the 2 anterior teeth for more stabilization of the guide. We placed our surgical guide, our implants, removed the remaining teeth, placed our multi-unit along with their temporary abutments, and this is the temporization for the upper arch. Now, here we can see the X-rays immediately after the surgery. And this is the soft tissue healing after 3 months, showing good gingival health and gum architecture. Now, we can proceed with our digital impression. So we took our digital impression with the upper and lower temps in place and without them. And now, instead of taking a regular intraoral scan body technique, we used a modified reverse scan body technique where we scanned all this temporary outside the mouth. But instead of using scan bodies, in this case, we made a modification to the library in order to switch the scan bodies with the digital analogs. So here we can see the shape of the temporary scanned with the digital analog. So this technique, it was demonstrated that it gives more accuracy than the intraoral scan body technique. And moreover, because soft tissue collapse immediately after we take out the provisionals from the jaw, scanning this temporary outside the mouth will help us restore this emergence profile in order to do our final design based on the oval-shaped pontic of our temporary. And like this, we can see here the scalloping of the gum after we remove our prosthesis. And this is the final outcome with an FP1 prosthesis in this anterior region. Now we can compare the X-rays. This is the X-rays, intraoral X-rays at 6 months after the implant placement. And those are the X-rays 15 months after the initial implant placement, where we can show a good bone stability over this period of time. This is a 1-year follow-up of the case. And what matters mostly to us doctors is to have a happy, smiling, and satisfied patient at the end. So now that we've seen those optimizations we did, can we truly say that this is the most efficient approach to use every day? In order to answer that, I will show you the flow chart that shows all the software, techniques, and workflow used in this particular case. As it seems a little bit complex and unpractical to use every day, it might serve as a proof of concept for future software development in order to implement these features in a more user-friendly solution. And thank you. Thank you. Thank you.
So how many works is to be a speaker? How many jobs? I can be the best Niklaus Pelang, Jan Linde, scientist, even the super scientific level. But it's not enough. It's a part of, very important. But it's not enough. It's not enough. We need to be good photographer, but it's not enough. We need to create some emotion. Without this final part, there's no deliver. To do this is to tell our stories. Stories is the fil rouge, to say en français. But without a story, we don't have a lecture, an effective lecture.
miss this man so much, like many of you. Diego will always be remembered. But for Megamind, he's more special, even more special. Because when I venture into this journey of Megamind, I had to start from scratch. And there were so many moments, it was so difficult that I almost gave up. And when I have those difficult times, I call Diego. And Diego always gave me his words of encouragement. And he and I shared, and we asked each other question. Diego, what is your idea, vision of what the future of implant educator? And we bounce off ideas. And he has been training those Cinderella's top 6, the winners. He and his clinician partner, David, they were so encouraging and kind to train our future leaders in dental education. And also the 6 Cinderella presenters who are chosen this year, his legacy will go on because his friends and his colleagues will continue to guide these future leaders in dental education. So with this in mind, I dedicate Megamind 2024 to our dear friend, Professor Diego Lopes. I hope you have that in your heart and think about him as you also watch our next 3 presenters. Thank you very much.
Okay, good morning. First, I also want to thank Diego because I met him, I think, several months ago this year in China. So I also miss him so much. Okay, before my presentation. So today it's my honor to stand here, to stay on this stage, to give my presentation. My presentation title is Multidisciplinary Treatment for Bone and Soft Tissue Augmentation in the aesthetic zone from China. My name is Yuesa. I'm a prosthetist, also I'm an implant surgeon. So first I want to share a video. It's beautiful, right? This is the video from my campus, my university. It is called one of the most beautiful campus, most beautiful university in the world. This is from Wuhan University. I like walking to chat with my friend on the street. I like beautiful city, beautiful campus, beautiful world. Like everyone like beautiful things. So aesthetic is very, very important for everyone. But when we face a challenge in the aesthetic zone, we have to find out where the patient wants to be in this zone. So let's talk about today's patient. The patient came to our office several years ago because he said he has unpleasant, appearance. We can see his face was asymmetrical. And when he smiled, we can see the mouth lifted to one side. And when we check the intraoral examination, we can see the oral hygiene was not so good. We can see the very poor oral hygiene. We can see the missing tooth for tooth 2-1, and also there is insufficient space for tooth 2-1. And also for tooth 2-2, we can see the crossbite. If we zoom in the aesthetic zone, we can see the missing, and we can see the crossbite, and also we can see the very crowded indentation for the maxillary and for the mandible. So what should we do? I think this is a complicated case, so we should do the treatment plan. First, we need to do the intraoral, like the oral hygiene extraction, and then we need to do a periodontology treatment to improve the condition, and then we need to do the orthodontic treatment to move the location of the teeth, and then we need to do the implant placement to replace the missing tooth, and then we need to do the prosthetic way to do the prosthetic restoration, and finally we need to keep everything stable. We need to do the review to keep everything good. So because of limited time, I only have 15 minutes, so I can only show you the key points. First, let's finish the orthodontic treatment. With the orthodontist, refer the patient back to my office, and they said, okay, you can start to your implant placement. But we can see actually looks like the tooth 2-1 was a little bit wider than the tooth 1-1. But the orthodontist said we cannot move, we cannot change the position in the anterior region. So we did the detailed design for the patient. We just copy the shape of 1-1 and 2-1 to the contralateral side for the 2-1 and 2-2. We can see there's still a gap between 1-1 and 2-1. That means this was not a perfect result, so we need to change. Maybe 1-1, 2-1, 2-2 together. Then to make it better and make the best way for the patient, and the patient accepts its solution. And we check the condition for the bone volume. We can see there is bone deficiency. We can see there is a horizontal bone defect. And of course, we can see why this is very important and why this is so difficult for the orthodontist to move the adjacent teeth, because there is a large foramen, I mean the incisive foramen between the 1-1 and the 2-2. This is also a challenge for us to do the bone augmentation and do the implant placement. So first, we need to check. We need to do the aesthetic risk assessment for the patient. And we also need to do the SAC classification for the patient. Because of the bone deficiency, because of the aesthetic risk, because of complexity for the kind of case, so we think the patient referred to the SAC classification should be a complex one. So what we should do? What we should do, the first one is we need to consider, because of the bone resorption, after the tooth extraction, we can see the bone resorption. If we place the implant with a standard diameter, we can see the exposure for the surface. But can we change our mind? Can we change the diameter of the implants? Can we place the implant with a small diameter, like the narrow size of the diameter? It's safe. It's possible. We check the diameter, we check the reference, and we check the systematic review, and we check the material analysis. And we found that actually, compared with standard diameter of the implant, we can see if we use a narrow diameter implants, because it can be divided into 3 different categories. If we choose the third one, I mean from 3.3 to 3.5, actually it's safe. We can use the narrow diameter implants in the anterior region for the single tooth restoration. It's safe. So we choose a 3.5 diameter of the implants, and also to facilitate the implant placement, we design digital guide. Then we print everything. We print digital guide. We didn't use the normal resin one. We used the metal one, and then we place the metal one to try the accuracy of the digital guide, and then we start to begin our implant surgery. We open the flap, we see the narrow bone, and then we place the metal guide onto the surface of the teeth. We can see it's very safe. Why? Because it's smaller than the normal one, and it's more stronger, and it's easily for us to see the water cooling, to see the direction, to see the drill. Everything was good. So it's very easy for us to control everything, to control the direction of the drill, to direction of the implant placement. And I said, because of the larger incisive foramen, it interferes the placement of the implant. So we just remove the nerve, we just remove the blood vessel, we remove the soft tissue inside the incisive foramen, and then we do preparation for implant placement, like the tension release, it's a bone perforation, and then we did another thing. What did we do? We use the patient's own blood to produce the CGF and AFG. What is CGF? This is called concentrated growth factor. This is good. And also we use the AFG. This is autogenous fibrin. Why we use it? Because when we mix these 2 components together with the bone graft, it can be better. It can make the particles into the block bone. We call it a sticky bone. Why it's sticky? Because from SEM observation, this is a sample from my patient. We prepare the sticky bone before surgery, and even after 3 months, I tested this kind of sticky bone. We can see the blood connects all the particles together to make it more stable. This is why we choose a kind of bone graft on the surface of the implants. So we place the implants, we pack the stick bone into the incisive foramen, and then we put just a block onto the surface of the implant. We use a membrane to cover it, and then you use CGF to protect the membrane. Then we suture. Everything was done. Very simple. very stable. And after surgery, we can check from a common CT, we can see the implant was surrounded by the bone graft totally. So what do we do after 6 months? We can see after 6 months, we can check. From the front view, actually, we can see it looks good. But if we check another direction, we can see there's a slightly collapse. There's a little bit collapse. That's because of bone resorption, that's because of the movement of bone graft. That was normal. But what should we do to improve that kind of phenomenon, to improve the outcome for the final one? We can open the flap, we can check everything. When we open the flap, we can see the stable bone graft was already formed. So that means we don't need to improve the condition for the bone. We don't need to do the further bone augmentation, but how to improve it? Further, we can see there is a very thick palatal part for soft tissue in the emplacement for the site. And also we can just change, we can just move the palatal part and insert into the facial part. That was easy, that was minimal invasive. That was very fast. Then we close everything with stable, and when suture was removal, we can see we just increase the contour, the soft tissue. And then we have to do the prosthetic way, because I'm an implant surgeon and also I'm a prosthetist. I need the provision to create the emergent profile for the patients. Then we use a digital impression to get a digital impression for the patient, right? Otherwise, the patient will kill me because of the metal ones. We cannot use the conventional, impression. Then we use the digital impression to design, to deliver the intervention, the provision into patient mouth. We can see the tooth 2-1. We can see compared with tooth 1-1, don't forget it. It's a little bit wider than the tooth 1-1, I mean for the contralateral teeth. If we compare the width between 1-1 and 2-1, we can see we change a little bit, but this was not the best one. So that means even we insert the provision, we cannot create the ideal emergent profile for the final prosthesis. That means we need to do another one. So after we just prepare the 1-1, we just prepare the 2-2, and also we prepare the 2-1. We make another provision and we deliver into the patient mouth. And we can see, use a retainer, we can keep everything stable. The patient was satisfied with the final outcome for the provisions. With this provision, we can create a more accurate and ideal emergent profile and the curve of the gingival and the papilla. And then we copy everything with the intraoral scan to transfer it to the technician, and the technician can make the orthoceramic restorations for my patient. So for the aesthetic zone, we can deliver all the ceramic, the ceramic abutment, the ceramic veneer, ceramic crown into the patient mouth. The patient was satisfied with the final outcome. Even after 3 years, everything was stable. When we recall the patient back to our office, and we check the common CT, we check the X-ray, we check the intraoral view, we can see everything was stable. So the patient was satisfied because we can see there's a big contrast between before and even after 3 years of the treatment. So today, I still have 3 minutes. So today, if you ask me what I should learn from this kind of patient, I will say, when I stay on the stage, I will tell you, if you want to choose this kind of complicated patient, if you want to solve the problem in the aesthetic zone, if you want to solve the complex hardened tissue of the problem in the aesthetic zone, we have to follow the take-home message. First, we need to use the multidisciplinary concept. Then we need to use the digital technique to help us to facilitate everything, to design, to communicate with the patient, to guide your implant placement, to guide your direction, and then maybe we can use a narrow diameter of the implant because it can decrease the failure, it can decrease the risk. Then we can use a steady bone graft like a sticky bone or whatever. Then we can use a connective tissue graft to increase the final outcome of the aesthetic effect. All of them, we need to follow the minimal invasive treatment because we need to treat our patient better, right? So I like my job because I'm a dentist. All of you, I think, a dentist. Why? Because I think dentists, actually, there are three different words. We are doctor. We have to treat our patient. We are engineer. We have to build our bone, build the soft tissue. And also, we are the artist. Why? We have to use a smart way to give the patient better life. This is all I want to say. And also, because this is a implant competition, right? So implant surgery is one of the most important surgery and one of the most important steps in the whole case. What is implant? Also, for me, is three words. Implant 2. Implant 2, we are planning to make the beauty for the patient. This is our aim. This is our destination. So finally, I want to show some of the cases because I wrote three books from acquaintance published, but sorry, this is in Chinese. I hope sometime I can translate it into English or into French. And also, welcome to China and welcome to my university. Welcome to one of the most beautiful universities in the world. And this is our hospital. If possible, welcome to China. And this is also one of my channel in China. We call it WeChat. We have more than 50,000 dentists followed this channel. So this is all I want to share because we can share some literatures, we can share some cases from this kind of channel. So thank you once again. Thank you, Mark. Thank you, organization, to give me opportunity to share my presentation. Thank you all. Thank you.
Great job. Great job.
Thank you.
Hello, everyone. I'm Mattia Manfredini from the University of Milan, Italy. It's an honor for me to be here in this wonderful location. And today's topic for me is hygiene versus sausage in one-time rehabilitation. And by one-time rehabilitation, we mean implant placement together with guided bone reconstruction. We are going to talk also about hygiene, so I hope that I will answer to some of the questions that you raised up before. And I will start with this this picture. This is the dream of every implantologist, right? Good, native, well-vascularized bone to place the implant, and the implant is correctly supported 360 degrees all around by bone. 10 minutes intervention, no pain for the patient, easy. But the reality that we are going to see every day in our clinical practice is this one. And this one is confirmed also from literature. Studies are telling us that 40 to 60% of the implant rehabilitation requires augmentations. And the most common condition, again, is this one. Enough bone to stabilize an implant, especially if we use this kind of design, but not enough to completely cover it. And if we do not perform GBR, our rehabilitation could not be stable over time. So, again, literature is telling us that we need bone around our implants. And we can go from small rehabilitation, like treatment of the dehiscencies that we're going to see today, from vertical, from huge augmentation of the maxilla, like in this case where we chose a custom mesh in order to treat it. So it's not a matter of the technique that you choose. It's a matter of the philosophy that you follow. You need bone around the implants, and you need to know how to perform these techniques, because GBR is something that should be in the hand of every surgeon every day. if 40 to 60% of the implant rehabilitation are in that condition, you should know how to perform these techniques. And I will tell you that the most common technique that clinicians use to perform GBR is a graft covered just with a resorbable membrane. And well, again, I will ask you, do you think that this is enough to treat deficiencies? Well, I will reply to this question, and the answer is no. Because we have three things. We have the pressure of the sutures at the end of the surgery. We have the pressure of the muscles during the healing period. And we have gravity. We live on the Earth, on the planet, and in the mandible, especially in the mandible, because we are talking about the lower jaw, we have gravity that moves our graft in an apical position. And we want this, we get this. And this, it's not 2 millimeters of buccal bone. So we are in a situation that it's not stable over time. And what can happen? Well, resorption of the bone can happen. And after it, if the soft tissue is not surrounded by bone, it can resorb. And we're talking about the buccal aspect. We're talking about the aesthetic aspect. So resorption is more than a nightmare than a dream. So the issue that we're going to address today is what's the more predictable technique between hygiene and sausage to recreate the correct buccal angle and to achieve the right subcrestal buccal position of the implant. Those implants need to be placed at least 1 millimeter subcrestally, but even in the buccal aspect. So we need a technique that helps us to guarantee the buccal subcrestal position even in that area, especially in that area. And well, we are at the main theme of the presentation. One-time rehabilitation, fixture, plus hygiene, or plus sausage to treat implant deficiencies. Two options. What literature is telling us about two-stage approach? We perform the guided bone reconstruction, we do the implant placement delayed. Well, native collagen membrane titanium meshes in an RCT study, if we check about the radiological results, they are comparable. No significant, statistically significant. If we check up the histological results, bone area, similar. Residual particles, almost the same. Marrow spaces, again, almost the same. So these two techniques, if we talk about histology and radiological results, are comparable. But if we talk about complication, well, we know that titanium meshes are more prone to suffer about exposure. So this makes titanium meshes a more sensitive technique, and it's a more reliable technique in the hand of expert surgeon. But still, in two-stage approach, literature is telling us that these two techniques for horizontal augmentation are comparable, but titanium mesh is more sensitive technique. So, one-stage approach, one-time rehabilitation, implants and reconstruction. Which is the best approach? Well, literature is not clear in this aspect, and actually there are no studies on that. So let's try to check it up and see if we have some results. Well, let's begin with the sausage. This is what we were talking about before. Sausage, it's not just a membrane and a graft. It's membrane, graft, and fixation. If you do not fix your membrane, you will have a dislocation in an apical position due to suture, muscles, and gravity. And this study is confirming that just with the suture. It's an animal study. They perform a defect here. They did a reconstruction, just bone membrane and tacks or blocks, but we do not consider that membrane, bone and membrane, bone, bone and membrane fixed. And the results of this study, after just suturing and performing a CT scan before and after in these animals, they saw that if they do not fix the membrane, they lose 50% of the graft in the coronal aspect, which is the critical one. If they fix the membrane, just 22%. And that's just sutures. No muscles, no gravity. You can lose more. So let's see the technique. We have a defect. The defect is confirmed on the CT scan. We see that it's an horizontal defect. There is enough bone to stabilize the implant, but not enough to completely cover it. It's 2 teeth defect, so we're going to perform a sausage technique. Let's get into the technique. Mediocrestal incision. Releasing incision mesial and distal. The passivation. The passivation is fundamentally every kind of reconstruction. The lingual and the buccal flap should be released properly, and they need to overlap correctly. We perform autogenous bone grafting with a simple scraper, implant placement. Even in cases where we need to reconstruct the bone, we need to place the implant in a prosthetically guided position. And we can easily check the position with pins, and after the implant placement, with pathfinders. We perform corticotomy because we are in the mandible and we want to augment the blood supply to our graft. In order to make a sticky bone, we can add some hyaluronic acid to our mixture of autogenous and xenograft. We fix the membrane in the lingual aspect and then the critical buccal aspect. We need to push the membrane in the coronal position in order to avoid the pressure of muscles and the sutures. And the suture, in cases of guided bone reconstruction, is always the same. It's a double-layer suture, horizontal matrices, and single dots. That's the technique. That's the result. After 4 months, CBCT was performed in order to rehabilitate the other side of the patient, so we took the opportunity to check it. And we have 3.4 millimeter and 2.9. Let's go to the hygiene mesh. I will go quite fast here because you saw it before. It's designed to treat implant dehiscencies because it needs to be stabilized with the implant, together with the implant. There are different shapes, and there were studies for the first time by me and the group of Milan in a first prospective study in 2020, a pilot study on 8 cases, and we are ready to publish the final results on 25 cases, a few months. We are waiting for the statistics. So they are easy to use, as you saw before. They reduce the cost, but I think that the more important thing, in my opinion, is that you reduce the time of the surgery. So you place the implant, you place the flat abutment. How deep you place the implant? First question. You place the implant according to the supracrestal tissue height development. You need to place the implant as deep as needed in order to develop the correct supracrestal tissue height. If the soft tissue is thin, you place the implant deeper and you choose a higher flat abutment. That's why they made 1, 2, and 3 flat abutment. I've never saw a soft tissue height less than 1 millimeter, but that's why they made the 3 the highest. So 1 plus 3 is 4, and 4 is the supracrestal tissue height, minimum, in implantology. Then you place the graft, you place the mesh, and you fix it. Again, you saw this before. Submerged healing, transmucosal healing if you want. Here a case of this study. Again, a contraction. Again, implant placement. You saw 1 millimeter, 2 millimeter and a half implant placement depth. The flat abutment takes the reconstruction to a bone level and not over it. Otherwise, we would have exposure because the cap will provide pressure to the tissue and can cause exposure. And the X-ray confirmed this. The implant is placed subcrestally, and the flat abutment takes the system to the bone level. The CBCT post-op confirmed the results and the buccal angle created. Simple reopening, removal, pseudoperiosteum type 1, we do not remove it. We can place a graft here if we want to augment the soft tissue. Really easy technique. The development of the supracrestal tissue height after 6 months of provisionalization. 1 year follow-up, 3 years, the tissue are quite stable. And also the bone is stable with the 3-year X-ray follow-up. So let's compare the results. Let's go to what we want to know. 25 cases of hygiene, 26 fixture of resorbable mesh fixed in the sausage technique. Well, the two techniques are quite comparable if we talk about marginal bone resorption. No big difference here. No difference in the probing depth. No difference in the bleeding on probing. No difference in the keratinized mucosa. I mean, hygiene has better results, but still no statistical significance. I'm a science boy. I want to see statistical significance in the study in order to follow a technique. But that's the thing we want to know. Hygiene is a more reliable technique if we talk about buccal bone augmentation. And this, my friend, is statistical significance. Let's go to the conclusion. If we talk about hygiene, of course we need implant stability because the mesh is fixed to the implant. If we talk about number of surgical procedure and we need to increment the keratinized mucosa, we need to perform 1 stage more in the hygiene technique. Hygiene is more indicated in non-self-contained defect because it's a non-resorbable membrane. Of course, it's a non-resorbable membrane, so it has a higher risk of exposure, and that makes meshes a more sensitive technique. It's more indicated for 1 tooth bone defect. If I have more than 1 tooth, you can use it, but it will be harder to treat the shape of the bone. Again, the main topic. Which is the best one to recreate the buccal bone angle? The results of the study that you saw before are telling us that for buccal bone thickness at implant platform, hygiene was better. Still good results for the sausage, but more predictable with the hygiene. And for subcrestal buccal positioning, of course, one thing goes with the other. Well, this is interesting. Future research, again, to answer your question. The position of the pin as coronal as possible in order to push the graft. A cover screw, if you use a company that gives you higher cover screw, this can help you to place the implant deeper in the bone and act like a tending screw in order to augment the most coronal part of the reconstruction with resorbable membranes. Since you were asking, we fix the hygiene from that protocol if the mesh do not follow the anatomy of the bone. If we have a straight anatomy, we fix the mesh. We won't leave it going like this. To have bone, we need to have stability. So if we fix resorbable membrane, why not fixing meshes? You know, we fix normal meshes. Why not to fix a pre-shaped meshes? What's the difference? We saw the shape of the bone. We decide if we want to fix it or if it's stable enough in order not to fix it. I hope I replied to every question, and I'm free after maybe. Thank you very much.
Good afternoon, everyone. My name is Chanyoung Park, and it's a great honor to present in this such a wonderful event in this beautiful city of Cannes. And I'd like to thank all of my colleagues who competed with me in the Megamind Final League, and also Megagen and Minec for organizing this such a wonderful event. So I'm a prosthodontist from South Korea, and also a husband and a medical officer in the Korean Army. So some of you might know, in my country of Korea, every man has to serve for the military for a certain period of time. So I'm the only person in this room who's serving for the military. So my topic today is about digital, a key paradigm in today's dentistry. But we all know that digital is not perfect yet, and we are in the transitional period. So that is why many clinics still rely on the combination of the conventional and the digital. So I felt the need to clarify the current status of the digital prosthetic workflow in an evidence-based manner. And as you've listened, compared to the previous presentations of the Megamind colleagues, my presentation will be a little more conservative, based on the basics and more of the fundamentals and the evidences. So please adhere to this. So today I'd like to discuss two aspects. First, advantages and challenges of the current digital prosthetic workflow. And second, what we should consider to minimize the errors in current digital prosthetic fabrication. So starting with the advantages and the challenges, we all know that digital simplifies lab workflows and reduces the shared time. And this is already accumulated in so many studies, as this systematic review shows. So there's nothing much to talk about this. And I think another major advantage of the digital prosthetic workflow is that more comprehensive diagnosis in a restoration-driven manner has become possible. And in my opinion, the development of the 3D facial scan has played a major role in this, in both aesthetic aspect and occlusal aspect. So if you look at the aesthetic aspect, when we design the optimal smile for patients, it is clear that we should consider their asymmetrical facial features. And some studies recently have given us some guidelines on this. So when setting the dental midline, it should follow the patient's asymmetric facial flow curve. And when setting the anterior transverse occlusal plane, it has to be parallel, following the commissure lip curve of the patient. So this is where the digital comes in, because by using the 3D facial scans, prosthetic design following the patient's facial features becomes possible. Another is the occlusal utility, and recent studies supports that using the anatomic landmarks from the 3D facial scans are reliable enough for setting the optimal occlusal plane for oral rehabilitation cases. Or if faceplate mounting is needed for some cases, we could use some posterior anatomic reference points from the facial scans. So for the occlusal plane, we usually use the Alatrue line or the Camper's plane. And for the arbitrary mounting, we could use some known reference points from the literature, such as the Bayron point, set from the posterior margin of the ear tragus, or the Bergstrom's point, set from the Porion. So this is a case example using some digital diagnostic tools. Now, this patient visited our clinic hoping for overall prosthetic rehabilitation. And by the looks of the initial panoramic view, there were some hopeless teeth and implants on the posterior area. And by the looks of the intraoral photo on the anterior area, we could see some severe attrition, anterior crossbite, loss of posterior support, which would indicate that space for aesthetic restoration was insufficient. So this means that full mouth rehabilitation is needed for the treatment. So first, we had to secure the space for aesthetic restoration, so vertical dimension had to be elevated around 3 millimeters, and it was taken using analog method, and this newly established jaw relationship was digitized and superimposed to the facial scans to form the virtual patient. So for the next step, virtual faceplate transfer was done, and as I have mentioned before, I used the Bayron point, 30 millimeter anterior from the posterior margin of the ear tragus as the arbitrary hinge axis. And for the occlusal plane, electrogoose line, retromolar pad, and the average value of the anterior tooth exposure for the elder people were used as the reference for the setting. And based on the setting, diagnostic wax-up was done with the 3D printed provisional crowns and dentures. For the occlusal scheme, mutually protected occlusion was set while checking the facial aesthetics so that the dental midline follows the patient's banana-shaped facial flow curve, and so that the anterior occlusal plane should blend with the commensurate lip line. So based on the wax-up, implant planning was done, leading to the guided implant surgery with the initial mouth preparation. And at this point, immediate provisional restorations were delivered with canine guidance in check. And with the virtual facebone mounting, not much adjustment was needed. So after waiting for 10 weeks, we switched to the second provisional restorations and checking all the tissues to make sure that we were now ready to fabricate the final prosthesis. So for the next step, final impression was taken in an abutment level by the analog methods. And with the cross-mounting casts were all digitized in a dual scanning manner so that we could design the final prosthesis which follows the morphology of the provisional crowns. So these are the finally fabricated zirconia crowns along with the final dentures and delivered to the patient. And this photo was actually taken 1 year after the delivery for the follow-up. And all the soft tissues, the prosthesis, the occlusal scheme, and the bones surrounding the implants were all stayed without any problems. So it was a brief case example, but a good example utilizing the digital diagnosis. So using the digital tools will allow a more comprehensive provisionalization in many aspects, which will allow more optimal prosthetic results. So we've seen the advantages of the digital tools, but the challenges, especially for implant cases, is that for full digital prosthetic workflows, their indications and accuracy is still unclear according to the literatures. And for us to fabricate digital prosthesis digitally, accurate digital impressions and accurate digitally fabricated casts should be mandatory. So let us see what the current studies say about this. The most current studies say that for digital implant impressions, in vitro studies show that their accuracy is already superior compared to the conventional impressions. But we should keep in mind that actual intraoral conditions would undermine the actual scanning accuracy. So that is why we have to pay attention to some in vivo studies recently. And according to these studies, the digital impression accuracy is clinically acceptable limited for short span cases, such as single case or anterior partial arch case, or partial arch cases with some distal free end cases. But it is still reported to be unclear for long arch or full arch cases. Now, don't get me wrong, because it doesn't mean that we cannot use full digital workflow in full arch cases. It is what the literature says. So it's up to you to interpret these results. And for full arch cases, still unclear despite the use of various auxiliary scan aids. But on the bright side, the accuracy of the digitally fabricated prosthetic casts seem to report clinically acceptable accuracy regardless of the range of edentulism. So combining the evidences, it seems that the ideal indication for full digital prosthetic workflow is limited for short partial arch cases. And I'm saying it again, it's up to you to interpret these results. So what does this mean? It means that digital is not perfect, so we have to take detailed care in every fundamental step for digital implant prosthetic fabrication. So let's take a look at what we should consider on this. Now, this is a case example using a full digital prosthetic workflow and also a story of a firefighter who suffered from a dental trauma with spontaneous pain and unaesthetic appearance on maxillary central incisors. And by the looks of the initial examination, the 2 teeth seemed hopeless to be saved and needed for some implantation. So careful planning was done regarding the facial aesthetics, to design the surgical guides for implant surgery. And the surgery was done, but the initial stability was not reported to be enough, so we had to wait for several weeks for the conventional loading. And after waiting for some weeks, digital scan body impression was taken. And this is probably the most important step in fabricating the prosthesis with digital methods. So what are the factors for successful scan body impressions? I'd like to talk about some fundamentals, maybe a little bit boring, but I think it's very important. So 3 categories: scanning condition, scanning strategy, and scan body choice. So let's look at the evidences. The scanning condition, the ambient lighting conditions would be important. And according to the researchers, illumination around 1,000 lux seems to provide optimal accuracy regardless of the scanner types. And it seems that compared to the triangulation system scanners, confocal scanners are less affected by the lighting conditions. So for your everyday daily practice, this may be one of the criteria for choosing the optimal scanner. And the ambient temperature. The changes in the surrounding temperatures of the scanning environment will undermine the scanning accuracy. So it would be advisable to keep the surrounding temperatures stable enough. And of course, the scan surfaces have to be dried enough to minimize the reflections and to maximize the scanning accuracy. Basic stuff, but very important. And next is the scanning strategy. About the optimal scanning distance, it is not still clear, but evidences say that too short scanning distances will cause oversaturation of the stitching of the data and may cause distortion when they are converted to the mesh data. But if it is too far, it may undermine the ability to capture the reflected light from the surfaces. So we should keep this in mind. And the scanning pattern, it will differ upon the scanner types and the scanning situation, whether it's mostly dentate or whether it's mostly edentulous with implants. And various studies have conducted researches on each clinical situations. So I concluded that it would be the best to follow the clinical manufacturer's recommendations or these evidences for choosing the most optimal scanning pattern. And finally, the scan body choice. In clinics, we usually use a PIC scan body or the titanium scan body. And for the PIC scan body, they are easily scannable since there's no surface reflections. But the problem is that only single use is recommended. And this is due to some deformation issues, such as repeated sterilization after use, or if excess torque is applied when the scanning is done. So for multiple uses, titanium may be the better choice, since it has more stable thermomechanical property, but the problem is that it has some reflection issues. So we should keep the pros and cons of each materials in mind when choosing the most optimal scan body. In the geometry, no straight consensus, but majority of the studies agree on one fact that excess sharp or complex structures of the scan body will undermine the scanning accuracy. And this is because these structures may get distorted when converted to the mesh files. So it may cause trouble in accurate matching with the scan body library. And finally, the dimension. Not much studies about the diameter, but there seems to be some certain pattern associated with the supramucosal height. If the surrounding tissues are mostly dentate, short length may be more preferred, but if it is mostly edentulous, longer length may be preferred. But it seems that between 3 to 7 millimeters of the supramucosal height, does not seem to be any significant difference. So what I want to say is that the optimal scanning strategy has to be crafted based upon the evidences. Maybe a little too conservative, but I think it's the safe way. For this case, I used a PIC scan body for single use, which was cylinder-shaped with only 1 or 2 decut area for matching. And to prevent the deformation of the scan body, hand torque was applied. And for this case, scanning direction was set from occlusal, palatal to buccal direction with zigzag pattern on the scan body area. So after scanning, interim PMMA crowns were designed and delivered to the patient, but we could still see some black triangle areas along with some uneven gingival lines, so additional recontouring was needed. to improve the pink aesthetics. And at this point, we could see some intact gingival architecture without any inflammation. So this meant that we were now ready to fabricate the final prosthesis. So for the next step, digital allows a more simplified transfer of the subgingival contour because only the scanning and the merging, assembling of the data is needed on the single CAD software. So by doing this process, we could design the final prosthesis more easily, respecting the contour of the interim crowns. And after that, the customized abutments and the final crown was fabricated. And for this case, I did not use any 3D printed cast. So another question. Is using the cast-free workflow without the 3D printed cast commendable for daily practice? There's no straight answer for this, actually. But according to the evidences, cast-free workflow may produce better prosthetic fit for very short span cases because they exclude the errors that may be produced by the 3D printed cast. But the problem is that we would all know that pre-adjustment on the model is not possible, which may cause longer chairside adjustment time. So for longer arch cases, these casts may still be mandatory. So regarding this, customized abutments were delivered, and I used the PMMA prototype so that I could prevent the misfit caused by the rotational errors in the internal hexagonal screw channels. And checking that everything's fine, zirconia crown was delivered with the patient recovering his smile. And after 1 year, all the tissues and the crowns were all maintained without any problems. So overall, digital smile recovery done without any problems. So it's time to wrap up our presentation. Now, digital allows a more comprehensive diagnosis in a restoration-driven manner, as I mentioned. And its indication using the full digital prosthetic workflow is expanding every day, but still unclear in long-term evidences on long and full arch implant cases. I think the most important thing is that we should keep in mind that digital itself is not the master key. So every clinical step has to be done with detailed care, following the fundamentals and the evidences. And most importantly, we should update our latest evidences and clinical perspectives about the digital issues. So these are the references. And thank you for listening.
Thank you. Before I closing remark, I want to thank all of you for staying and waiting for every single one of the 6 presenters to present their cases. It's not easy for them. Probably for some of them, this is the biggest stage they've ever been in their life. Right. And thank you so much for hosting us. Yeah. And there's a great excitement is in there. Megamind is an annual event, and it's only our 3rd season. And our goal, like I said, is to secure the future of dental implant education. Thank you very much, and please go out there and spread a good word and give our Cinderellas the words of encouragement during the lunchtime. Thank you very much. I'm Mark Kwan.
Thank you. Thank you, Dr. Kwan. Thank you very much for this amazing Megamind session. So let's have a break lunch now. Hurry up, because in 30 minutes, 35 minutes, we're taking back our seats for the session of the afternoon. Thank you very much. Sorry for the late, but it was very, very quality work. Thank you.